even though you're all highly intelligent, the one thing you don't have yet for the most part is experience actually in the field of medicine. Psychiatry is a wonderful career. So for those of you in the line considering psychiatry, that half the battle is just picking the right career. I think it's, rewarding in many levels. But some of my background was already given. Just so you know, the kinds of patients I see, since I'm a child psychiatrist, unlike peds, where once someone turns, like 18, you kick them out because it'd be creepy to have like a 19-year-old hanging around the fishbowl, in the peds office. In psych, even though children turn into adults, I still see those children as adults. It's great. You really, really don't lose that longitudinal care. And I was fortunate enough to have just stepped right into an amazing job right out of residency and fellowship down at UNC. I've been with the MSU Department of Psychiatry since 2003. And even though I mostly see teenagers, I see a lot of little kids also, a lot of college students that were former teenagers because I didn't kick them out of my practice, the occasional older person, but I do telehealth. I've been doing telehealth for about 6, 7 years. So even though when COVID hit, it was sure nice to know how to do telehealth, in psychiatry, most of us have been doing telehealth effectively for a long time. I've been working since about 2004 with a rural Medicaid population from Stanton, Michigan, which is about an hour and 20 minutes sort of northwest of Lansing in Michigan. We do this thing with our hands, like, so if I'm right now I'm on the empty campus of Michigan State right here, and then like Stanton's over here, whole different world. Rural trailer parks, just a lot different than this sort of suburban, light urban setting that is East Lansing and Lansing. And then for a lot of years, once every 2 months, I spend a weekend at the inpatient adult unit at St. Lawrence Hospital, which is now owned by Sparrow in Lansing. So a lot of different kinds of patients, outpatients, some from wealthy families, a lot of poor children, adults with schizophrenia, telehealth, and autism clinic. So that's my background. Now we're going to just go through a lot of different things that I think are things that I wish I would have known when I started this job. One is, how do you approach adolescence? You don't want to be like, anyone seen that old, the Simpsons series where they invented this dog called Poochie that's supposed to be like, hey, what's up, kids? That's going to freak kids out if you try to force the coolness. You got to see a kid alone, though. These kids look so much different without their parents than with their parents. There have been kids where I could have sworn they were autistic when they were with their parents. No eye contact. They didn't engage with me at all. Parents left. Bloop, hey, Dr. Smith, how you doing? I mean, it was night and day. So you got to get them away from their parents, at least if they're 10 or older. I don't want to freak out some little 6-year-old by the bearded man. Or if someone has social anxiety, or they've been abused, or separation anxiety, maybe you wait a few sessions before you make that switch. But at some point, you need to see these kids alone. And what's especially important now with telehealth is that with telehealth, sometimes I think we're alone, and like grandpa is like right next to the kid, just out of view of the camera. And so I'll ask, are you in a private location? Are you fully alone? Let's talk. Because so much more material comes out when the kids are alone. I pretty much ask, with the parents there, suicide, sex, drugs, all that stuff. Then the kid's alone. Suicide, sex, drugs, etc. Because you often hear different answers. And other things that are sensitive, self-injury. You have to ask about things directly. Even with the kid alone, if it's sensitive, they're probably not going to just spontaneously tell you about things that are eating disorders, sexual orientation, gender identity. I ask in a very non-judgmental way all those things directly, and most kids are pretty comfortable and honest with telling you things, especially if you can establish some rapport. But the problem is, don't get a kid alone and immediately be like, hey, Billy, you want to kill yourself? Like, you got to ease into that stuff. You got to be like, hey, Billy, do you play video games? Almost every boy I know, it's a generalization that's true, plays a lot of video games. So you work your way up to the sensitive stuff. Ask some easy questions first. Hey, how old are you? What grade are you in? The key is, and I tell my fellows this, get the kid talking. That's the key. If you get them talking, they'll tell you stuff. And then once they tell you something provocative, don't do what I call the Puss in Boots face. In the movie Puss in Boots, there's this one cat, not Puss or whatever, but this other cat, whenever Puss in Boots does something provocative, this cat goes, oh, like, you don't want to have that face. Even if you don't verbally say, don't say, oh my goodness. You don't want to have the face that just has like that oh face, like, oh, like you're shocked. So if someone says, I smoke a bunch of weed, even though inside I'm saying, oh crap, I've seen the dark side of weed, you don't kick into your like PowerPoint lecture about weed. You find out more. You say, oh, you smoke? Okay. How much? What do you like about it? And sometimes if someone says they don't use any drugs, with a lot of teens, I'm sort of skeptical if they've never tried anything. I'll say, Oh, you haven't tried stuff? Oh, why not? Almost like I'm sort of expecting, like, oh yeah, most people sort of at some point try something, and then kids are often shocked, like, what do you mean? "Oh, okay," and then they're like maybe a little bit more honest. Or sometimes they say, "Oh, okay. It sounds like you're not using anything. What if we got a urine drug screen today? How would you think about that? Oh, okay. Now I'm remembering some things I used. Okay." A quick way to build rapport, especially before jumping into the provocative stuff, is to show interest in something they care about. Video games is one thing, but you got to get like a social media inventory. I'll often say, what's the main thing you like? Instagram, Snapchat. They don't use Facebook anymore, just so you know. And then you'll say, oh, would you mind showing me? Like, oh, whatever. Of course, kids, they love to show that stuff. Everyone likes to be on their phones. What sports do you have? Do you do art? Oh, I love art. Would you mind showing me a piece of your art? And then you analyze it. Anytime I chat with a kid, I'm always working. So even stuff that sounds like small talk, it's never small talk. It always has a function, and often it's a very important function. So that was about how to approach them. Self-injury is an area that I've been published on a little bit. Part of the reason I don't freak out about self-injury is it's much more common than it used to be. It used to be in the old days that if someone cut themselves, you almost always assumed, oh, cut yourself, borderline, and you filled out the chart. No, most people that cut themselves these days do not meet criteria for borderline personality. And frankly, they're not even usually suicidal. Most cutting is more of a emotional regulation, trying to calm down kind of thing. But you want to find out with anyone who cuts what the function is. And you don't want to, once again, freak out about it. But cutting still concerns me because cutting, sort of like a high fever, is almost like a non-specific thing that tells you this kid's in pretty rough shape. Like they're pretty distressed. They're not coping well. And we know that kids that cut are in general at a higher risk of suicide. Not typically through cutting, unlike like that 13 Reasons Why show where, spoiler alert, someone dies by cutting. Um, Usually it's by another means, but it means that someone's overall is more distressed. And you might look for things like long sleeves or baggy clothing for self-injury, eating disorders. You got to keep both your eyes open and also your ears open with these teens. Another thing that I've learned over time is the whole, avoid jumping to conclusions. And then the second part of that is trust but verify. And I'll explain. So in terms of avoiding jumping, it's good to know generalizations. It's okay, but you don't want to assume that that individual like ties into that generalization. Generalization is more like a good to know this might be the deal, but you always got to find out with that individual, and you especially don't want to stereotype, which is when it's a bad generalization. It's something that just discriminatory, whatnot. We all have implicit biases, especially important with cultural stuff because I teach cultural psychiatry, and I used to think, oh, if I just tell everyone here are the top 10 cool things to learn about Russian people, you'd be like, oh, everyone's great now. But that's like the tip of the iceberg is knowing a few general things. But you don't want to have those general things be a weapon. Like, oh, I'm seeing someone from this background. I'm going to assume this about them. No, that's not the case. I mean, I'm a white male. You could assume many things about me. Some of them may be true. Many of them are probably not. And then also it's good to realize, and I have to tell myself this repeatedly, is that most patients are better in person than on paper. Almost all patients, you can find something you like about them. I even see some patients where they, like molest babies. That's awful. That's horrible. But I still, if I'm going to try to work with that person and try to be helpful to them, I got to find something about them that I can connect with on some level or like about them. Otherwise, it's very hard to treat someone and have a relationship if you just purely dislike that person. Um, and so usually when I read the chart, I go, oh no. And then I read the person, I think, we can work with this. And then trust but verify. So you don't want to be too skeptical of folks, but you have to know that a lot of things it's hard to be direct about. So especially with children, I'll see a child and they'll say, I feel great, everything's fine. I talk to the parent and they say, oh, last night my kid tried to overdose. You go, oh my goodness. It's always good to have collateral informants. Being a child psychiatrist is like being a detective. You want to have different sources. Scales, I don't think we want to over rely on scales. Scales are usually just basically DSM criteria thrown into some sort of checklist form. But some kids feel more comfortable checking the boxes than telling you directly what's going on. And then anytime you suspect substance use, because we don't want to say, you look sort of sketchy to me. I'm going to test you, but you're all right, I think. I want to treat everyone equally. So if I suspect substance use, I'm checking the maps. I'm doing a urine drug screen. Pretty standard. I don't want to sort of pick and choose based on how I just sort of gut feel about someone. And then I'll tell you the grandma story. The grandma story is that as a resident, I saw this grandmother who was very depressed, and she had a reason to feel sad. Her daughter had died in, I think, a motor vehicle accident, and I gave her, some medicine. Didn't seem to help. She went through grief counseling. Didn't seem to help. Tried about 3 medicines, and finally, at some point, worsening depression, became suicidal. We admitted her to the hospital that I worked at, just a few floors above where I was at. And while she was in the inpatient unit, I got a call from one of my colleagues. My colleague said, I want to give you an update on grandma. Because you're the outpatient doctor. And we found out some interesting things. And I said, oh my goodness, yeah, what's going on with grandma? I'd love to know more. Oh, here's what's happening. Grandma's smoking crack. Oh, what? Grandma smoking crack? Yeah, she's been smoking crack for about 6 months. I thought little old grandma, I might have asked her about substance use at some point. I might have even been like some med students or residents where I might have said, here's a silly question, but do you use drugs? But she tearfully told me after she got out of the hospital that she'd been using crack for a while, but just felt too embarrassed and didn't want to hurt our alliance by telling me that she was smoking crack. So once again, I screwed up because I assumed certain things were not, no chance, whereas substance use has to be a big thing on any differential, especially when conditions aren't getting better. All right, next thing, mood swings, and we all like memes. So if a patient says, I need a mood stabilizer, I have extreme mood swings multiple times a day, what's probably going on? We don't want to fall in these traps of like mood swings equal bipolar. In most cases, mood swings do not equal bipolar. And borderline personality is something that is fairly common. And these mood swings are more often angry, not necessarily euphoric. They can happen multiple times a day, and usually in response to some sort of interpersonal stressor. Well, I think one of the key easy ways to tell apart borderline from bipolar is that folks with bipolar disorder typically have a decreased need for sleep, whereas you don't see a decreased need for sleep in many other conditions. I mean, if you're on cocaine, you might be able to stay up for a few nights in a row, but you're going to have a big crash. Folks with bipolar can stay awake for days or weeks with very limited need for sleep. So you want to consider this diagnosis in patients that have chronic dysphoria. They just say, I'm just unhappy all the time. And you're like, wow, nothing seems to help. CBT doesn't help and medicines don't seem to help. Um, so what you really need to think about for folks with borderline personality is what you've probably heard of, that DBT. And I don't think you even have to have borderline personality to benefit from DBT. I send a lot of the teenagers I work with over for DBT when they're teens that just have trouble with emotional dysregulation. They don't tolerate the stress in their life very well. They need to get some mindfulness and other skills, and it's a great program for that. What I do find, and often like to tell my residents, like little tips as far as things you can say that are good for the alliance, but also get your point across, because you don't want to fight with your patients, is if I have a patient that is pushing me, like, and they don't have to be borderline personality, but if they are basically saying, I want this benzodiazepine, and if I think this benzodiazepine is not going to be in your best interest for you, it's going to be potentially harmful, you don't just say, no benzo for you and be like sort of real stern about it. You essentially might say, you deserve the best care, and I'm not willing to do anything that would potentially harm you. And so you're basically saying everything from a place of caring. It's not a place of just like, I'm depriving you. It's like, oh, I'm really worried for you. I think that this can make things worse, and so I'm not willing to do that. I'm sorry that we're on different pages, but what you're asking for is not the best care. And that sentence, it's genuine, but it's also something I've used a lot. Tends to work with my patients because I don't get fired that often. I get fired occasionally, but even with folks with borderline personality or other conditions, usually we can find a way to constructively work together over time. And what happens, unfortunately, a lot of parents assume their kids have bipolar or borderline because they're moody, but moodiness is fairly normal as a teenager. I have 2 and almost 3 teenagers in my household, and they went from being like, yes sir, and dad, you're the smartest, to being, you're an idiot, and and I don't think it was all my fault. I think some of it's biologic. So some of it's just teenage stuff. If a teenager is like irritable enough every day and explodes, and especially if they go over the top with physically assaulting folks, that can be something called disruptive mood dysregulation disorder. That's a little different. But we have to make sure that we don't assume, like, often I think we make the mistake if we hear the word like moody, we equate it to a disorder, or focus, we equate it to a disorder. That's not the way psychiatry usually works. It's like a preponderance of stuff in the overall story. The other thing we got to avoid doing is, if we see someone once or twice and they're acting as though they have a personality disorder, don't assume they have a personality disorder. It has to be really something that you see longitudinally over time. And the story I'll say is basically something about me. I think there are 2 things I mentioned about me, because I can give permission for these. Is that a long, long time ago in my life, in my early 20s, I had a girlfriend where, while I was dating that person, I think I temporarily met criteria for borderline. If you whipped out DSM for me for about a month or so, I was meeting criteria. But I was never meeting criteria before that relationship, and I've never met criteria since then. So I think for some folks, if they're under extreme stress, if there's a relational issue, or if they're maybe like a stockbroker and the stock market just crashed, they can act a certain way under stress that maybe don't act in other situations. So personality disorders really have to be, global and pervasive. They can't just be in one specific situation. And the good news is, even if someone has a personality disorder, they can and often do get better. Most studies show that either with teenagers with this diagnosis or even adults with diagnosis, with interventions, most individuals no longer meet criteria 5 years later when they receive care. So I think that's very hopeful. Another thing I often hear, folks come in and tell me, Doc, I'm really paranoid. So what do you think's going on? If someone says I'm really paranoid, I mean your thought is, oh, paranoid schizophrenia or something. Individuals with true paranoia almost never say I am paranoid. Just as someone who's really losing a grip on reality almost never says I need help, I'm going crazy. It's typically folks with anxiety disorders that say things like I'm paranoid or I feel like I'm going crazy. Um, and so that's often what you have to think about. Because if you have enough insight to recognize something is not quite right for me, that's the kind of insight we don't often see in some other disorders. And I know that social anxiety, that's the main one that makes you feel like everyone's watching you. And you might even feel like they're talking about you. It doesn't mean that you're hearing voices or etc. And my example about me again, this whole thing won't be about me. This is the last one. But I remember when I was in college, another dating scenario, or in undergrad, and when you're talking to someone, you share a lot of stuff. You start dating, and I was like, don't you hate it when you walk across campus and you see folks like sitting on the benches, and you pass them, and you think they might be talking about you, or they're looking around, they might be judging you, and the person I'm dating said, no, I have no idea what you're talking about. Well, oh, sorry, should have shared that. I had a little social anxiety here. So it makes you feel a certain way, and it can feel like paranoia, but it's not the classic paranoia we're talking about for a psychotic disorder. Another thing I hear all the time, so many kids come to me and they'll tell me, oh, yeah, I hear and see things. Another time when you're thinking, oh, my goodness, this child is psychotic. Not usually. Um, Childhood onset schizophrenia is very rare. I diagnose very little bipolar or schizophrenia before the age of about 16, 17. Most often, if you hear that complaint of hearing or seeing things, most often it's anxiety, um, commonly post traumatic stress disorder. In addition to anxiety, sometimes if there's intellectual disability, there can be sort of a misinterpretation of like your inner voice or other things. Substances can definitely cause, um, you know, psychotic symptoms. They can cause any sort of thing. And pot, even though we think, oh, marijuana is not so bad, if you become psychotic on marijuana, half the time that translates later into schizophrenia. So marijuana can be really dicey. Depression can have this, psychotic symptoms. Medical conditions can have things that sound psychotic. I saw this one family where the kid said, "Oh yeah, at night I see things move around the room. There are, spirits that shake the walls. I've been touched. I hear whispers from these spirits." And I told the parents, I said, "Do you know that Billy? Billy says he's hearing spirits and things are touching him." "Oh yeah, we all do. We're all getting touched. Everything's shaking." Okay, well that's a little different than just one person experiencing it. Then either it's the conjuring or it's a family where their intense belief system is influencing other folks in the home. And then often a little bit of quasi psychotic stuff is pretty normal. I almost guarantee almost all of you have had some quasi psychotic things. Have any of you ever felt a vibration or tingle in your pocket, assumed it was a phone, and there's no phone there? I feel that sometimes, that you had a hallucination, because it's your body's misinterpreting either the wind or just phantom things. It's called a phantom tingle. Or have you ever thought you heard your name from the next room, or someone call your name, and no one called for you? That's quasi-psychotic, but that's a really common thing. Also, during grief, it's common to maybe hear the voice of the deceased, or maybe see them briefly out of the corner of your eye. During sleep, there are many common hypnopompic, upon awakening, and hypnagogic, falling asleep hallucinations. And then suggestibility. I've had some kids where I know they're like little kids watching The Walking Dead and other stuff they should not be watching. And their parents will be like, yeah, they're seeing stuff. And I'll talk to them. They see normal. And I'll say, do you ever see clowns? And they go, yeah, right behind you. Where was the clown like 2 seconds ago? It's a suggestible thing, these kids that are watching all these shows. Another most common reason why kids come to see a child psychiatrist: behavioral issues and aggression. So if you hear that a kid's aggressive, what's going on? Like a fever, aggression also is a non-specific kind of thing. Lots of things can be underlying, because for kids it's like all this stuff's going on underneath, and then it comes out in the form of the symptoms. But it could be a traumatized kid. It It could be one of those with that reactive attachment disorder. There can be behavioral disorders where nothing else better explains it. ADHD, anxiety, depression, you know, so many things that can lead to aggression. And once again, if it only occurs in one setting or with one particular person, this is more likely a behavioral or relational issue, unlikely to respond to medicines. Medicines don't treat behaviors. Well, and the honest thing is they do a little bit, but it's very hit or miss. It's like a Las Vegas slot machine that never pays off. But in general, medicines don't treat behaviors. So you want behavioral approaches first. And then, but if things are bad enough, I've had kids that have taken over schools, that have stabbed teachers. Those kids eventually, once you've tried maybe gentler things, might get an antipsychotic or mood stabilizer. A lot of children these days are on antipsychotics. Almost none of those kids are psychotic. They're typically given antipsychotics for other things that we're targeting. Because in child psychiatry, often we say we don't really target diagnoses with our pills, we target symptoms with our pills. And then we also know that if your aggression is more like impulsive, like short fuse, that might respond to medicines sometimes. If you're more like planning, like, ooh, my sister made me mad, I'm going to wait 2 days and then I'm going to get her. That's that predatory, premeditated, not much medicines do for that at all. And that's real spooky because if that's like the callous, unemotional type of like personality thing, that can, grow up to be some bad stuff like antisocial. I run an autism clinic, and so often folks will come in and say, my 2-year-old or 3-year-old doesn't speak at all. Is my child autistic? The answer is maybe. But the tricky thing is, in the old days, like 20 years ago, when I was on the scene, sort of first, we only diagnosed autism in 5 in 10,000 kids. That's not that many kids. 5 in 10,000. Now it's up to 1 in 60. Some people say 1 in 40. That's a big change. Are kids suddenly just becoming autistic that weren't autistic before in the past? Not really. We don't think so. We don't think vaccines influence it. We're probably diagnosing more cases of high functioning autism. But the core of autism is social deficits. If a child has relatively intact social skills, I don't care what other problems they have, that child is probably not autistic. It's also possible for some kids to have like some traits that sound like autism that overlap with the criteria for autism, but not be autistic. A lot of folks have sensory sensitivities. You can have kids that are very inflexible behaviorally, like they don't roll with the punches well. That can be part of autism, but it's often not part of autism. And then speech and language delays. Really, the key way to differentiate between speech and language in autism, speech and language not in autism, is compensatory behaviors. Does that child who is having trouble with verbal communication compensate in some way with nonverbals? Are they pointing? Are they gesturing? Are they really trying to get your attention? Are they making up for their lack of verbal stuff with other stuff? If they're not frustrated by their inability to communicate, if they're not doing some compensatory stuff, more concerning for possible autism. Another classic one, we have definitely a number of college, law, medical students come over with this. I can't focus. What is going on? Well, if you were diagnosed before the age of 12 or if symptoms before the age of 12, there can definitely be legitimate ADHD diagnoses. ADHD does exist. The problem is if someone doesn't have symptoms until they're in their 20s or 30s or beyond, they've done studies of this, occasionally can be ADHD that was just missed before, especially maybe the inattentive type. But in most cases, it's probably anxiety, sometimes marijuana. We had one classic case in our resident clinic a number of years ago where we had a law student that came in and said, I can't focus. I really would like a stimulant to help me focus. And we went through the whole evaluation, and, this law student knew all the criteria. I'm having all the criteria. And we go, oh, okay. And then I told the resident before they signed out, and I said, you know what? Let's not prescribe a stimulant today, but just explain to this law student that, part of our standard thing is that we get a urine drug screen for adult patients. And then the resident was explaining it to the law student. The law student just nodded, smiled, stood up, and ran out of the clinic. Never came back. So, maybe there was some performance stuff there. There probably was some drug use going on there. But, it's a neurodevelopmental disorder. There should be some disturbance earlier in life. But anxiety can look like ADHD, PTSD, anything that distracts you, depression, worse concentration, being oppositional, I just don't want to do work, hearing or vision problems. There are lots of things that can masquerade as ADHD. It's really a clinical diagnosis. No matter what people tell you, there is no EEG exam. There is no lab test. There's no imaging. Even neuropsychological testing doesn't tell you for sure. It's really based on, clinical reports and observations. What are things looking like at school? What are they like at home? Where in multiple settings does someone have ADHD-like stuff. The problem with neuropsychological testing is that it can put you in front of like a computer and do this stuff called the TOVA, where like if this pops up, hit the button. If something else pops up, inhibit and don't hit the button. And that doesn't really necessarily always really replicate real life situations. So I do like neuropsychological testing, but it's just one extra piece of information. It doesn't. There's nothing that totally clinches it for me. The other thing we have to wonder about, and this is why I think it's great that psychiatrists, go to medical school, is that we know enough about other stuff to know, is this really psychiatric or is this other stuff? I saw a teenager one time where everyone said, "Oh, this kid is so somatic. He keeps falling down and breaking his bones. He's got, he's must have pseudoseizures and other stuff." With pseudoseizures, you don't fall down and break your jaw open all the time. And I said, "This kid's having real seizures. You all need to work him up better." And then they worked him up better and said, "Oh yeah, actually he has real seizures. Are bad." But I knew enough to say, you're not wetting yourself when you're doing this somatic stuff. I knew enough to say this does not sound like psychiatric to me. But you got to look out for, substance use can cause any symptom known to man. So cannabis, inattention, memory. If a family history of psychosis, watch out for converting to schizophrenia. Stimulants can cause a lot of anxiety or psychosis. Opioids can make you really depressed. And the key is you really don't want to diagnose a major psychiatric disorder when it's in the midst of some sort of substance use. I usually like to wait about 2 months or more of just being totally free of that substance, until you have a good idea of what's going on. Although I will say in general, it's hard to prove, but if someone was really smoking cannabis one time a week or less, I'm probably less concerned about that substance having a big impact. But that's, I got to work out that out with my individual patients. You also have to suspect a substance use when somebody wants a medicine really bad. I see a lot of patients with ADHD. They're not usually jonesing for their stimulants. If they like run out of stimulants for a few days, they're not banging on my windows trying to bust into the clinic. Someone that has on some benzos, I'm actually trying to encourage them. Please take your benzo; it'll help you. They're not the ones that are like, I need to triple my dose. And so if the more badly someone wants it, it's almost like the less I want to give it to them because I have that feeling of like that's not typically how it goes. People usually aren't jonesing for these medicines. And then medications, medical conditions, even medications, psychotropics and non-psychotropics can cause psych symptoms. And it's real confusing because someone's on a bunch of psych meds and you're like, they're having psych issues. Oh, is it the psych meds that are causing the psych issues now? That's why it gets so confusing when someone comes and sees me and they're on like 8 medicines. I can't tell what's doing what. One story I thought was interesting is that when I was a resident, I saw someone in the emergency room and the ER doc said, "This person's crazy. See this person, you're the psych guy." And I saw this person and he was like, "I guess I can't stop moving. I got to sit up, get down, sit up, get down. I got to move around. Oh. And he was like walking around the room. And being an intern, I thought, man, this guy's bipolar. We need to give him a bunch of drugs for his mania. And I explained the whole story to my attending. And my attending was like, intern. This guy has no psych history. He's 45. He has a lot of GI issues. And he's on the medicine compazine. No, I'm sorry, promethazine, which is Phenergan. And like, don't you know, intern, that promethazine has the same similar structure as some antipsychotics? So you probably guess this guy was having akathisia. Whoa, so we took him off the promethazine and he was fine. If I had my way, we'd have locked him up and put him on lithium. But I was a clueless intern, so thank goodness for the attending. But basically, any medical problem that can affect your brain can cause psych stuff. On any boards, question: depression is the most common comorbid psych condition, so you're always thinking about depression, no matter what the medical thing. But you got to watch out, for thyroid disturbance, sleep apnea, and the 2 biggest ones: head injury, seizure, as far as causing psych stuff. And it's not always true, but in general, if it's a visual hallucination or like a tactile thing or something, it's more often a substance issue or a medical issue than maybe a primary psychiatric disorder, which would more often have auditory hallucinations. All right, so review some meds here. Stuff to know about meds. With great power comes great responsibility. Basically, the psych drugs that I have that are more potent often have more side effects. It's not fair. That's the way life is. The other thing is, before I get in there and start like changing doses and add new stuff, make sure the person's taking the medicines. So many times I've gotten in there and thought I was so smart coming up with these clever little regimens and I was cranking up doses or whatever when the person wasn't even taking the medicine. And so you really always check for adherence. The word compliance is considered sort of punitive, so the best word is treatment non-adherence. And a lot of times kids, they can't even swallow pills. I always ask a kid, can you swallow pills, or ask the parents. Often it's good for me to know which medicines are sprinkled because these kids can't swallow pills. Other reasons for stopping meds, because patients often won't tell you if they're not taking the medicines unless you directly ask, like, side effects, ambivalence, like, am I really want to take it? If a patient tells me I'm on the fence about really taking this, I'm not saying, oh, on the fence, great, here you go, here's a script. I don't like to prescribe if someone's on the fence unless I feel like it's like an urgent matter. Meds are expensive, even some old ones. Clomipramine for OCD used to be like pennies on the dollar, dirt cheap, like 10 years ago. Then a bunch of companies bought up the generics, and then now clomipramine is like 100 or 200 bucks. So you always got to make sure you know how expensive stuff is, because you don't want to, hurt someone financially. And then sometimes the med's not working fast enough. Like, oh yeah, I took my Prozac 2 days, didn't work. See ya. Doesn't work that fast. Or I'm feeling great now. Bye bye Prozac. So there are many reasons why folks aren't taking stuff. You need to figure out what is the reason. But in general, you should know that with most medicines, I mean, I still look at Medscape and Hippocrates and stuff too. But about half of the therapeutic dose you start with, and then after just 3 or 4 days, you can often increase it as long as they're not having any side effects, because most kind of side effects pop up right away. That's a nice thing. You'll know very early in a course something, are you going to get side effects or not? Except for, and I always got to ask about this directly, sexual side effects, weight change, and maybe allergy. I mean, allergy might just take a few days or a week or two, but um, but then I always say, oh, we're doing great. You're been out for a week. Yeah, no benefit yet, but it's great. You already passed the side effect period. Now let's just hang in there and see what benefits we can get. Because the benefits, depending on the medicines, may take, not with stimulants, those are like immediate, but other than stimulants, most other drugs take days or weeks to really benefit. And then with kids, basically, I just chop the starting adult dose in half, and then I increase. For the elderly and kids, it's like the whole start low, go slow, is what we say. SSRIs. Um, Good to know. Best in class. A lot of times the old stuff is still the good stuff. Don't believe the drug reps if they just say, oh, this new thing is so superior. Rarely is that the case. Rarely. Fluoxetine is the best thing we got for kid depression and for adult bulimia. Because FDA approval doesn't always tell you what's really good. FDA approval tells you, like, what does someone go through the marketing process to get it approved, legally. But although fluoxetine is actually FDA approved for bulimia, sertraline is my go-to for child and adolescent anxiety. It's been studied the most. And pretty much almost any SSRI or SNRI is good for adult depression. You can pick whatever you want for the most part. Luvox, fluvoxamine, good for OCD, does nothing for depression. I don't know why. It's an SSRI, doesn't help depression. And then I beg, if you become a family doctor, pediatrician, or psychiatrist, don't be scared of the black box warning for suicide in youth. In fact, our studies say that actually suicide in youth probably went up after we limited our SSRI prescribing, because folks were scared to give these medicines. I still inform folks that occasionally these medicines can make you feel worse. Supposedly it's about 1 in 100, maybe a little bit more for some other ones. Do I talk about them? Nope. Looking here. But venlafaxine, paroxetine are a little bit dicier. But overall, we think that it's overall lowers the risk for suicide. We can't prove it as much as, like, like for board questions, lithium lowers suicide in bipolar folks. Clozapine lowers suicide in folks with schizophrenia. But don't believe the hype on the labels with that. SSRIs don't work as good for OCD or PTSD. So I think it's really important to get other interventions for OCD and PTSD, like trauma-focused CBT for PTSD or exposure therapies for PTSD, something called exposure response prevention therapy for OCD. But then medicines are helpful also, but medicines almost never do the full trick. And with these medicines, especially for OCD, you have to give them longer-term trial. You got to give them about 3 months to see if they work, and at higher doses. Zoloft is probably the main one studied for PTSD. And then combination, I always say it's like having two fists in a fight. Medicines plus therapy. If someone's especially moderate to greater severity, I often recommend that combination. Stimulants. I like stimulants in general. I'm careful with how I do them. I want to have a good diagnosis of ADHD. I want to monitor how things are going, but very effective. And fortunately, they're way more effective than the non-stimulants for ADHD. About 85% response rate, which is really good. They even had studies where it was like stimulant versus therapy versus stimulant and therapy. Stimulant therapy did like a little bit better than just stimulants alone, barely. These are really effective. So non-stimulants, I prescribe them, but I don't expect them to be as effective. But if someone has tics, I like one-stop shopping. Medicines like clonidine might help both tics and hyperactivity and impulsivity in children. Ritalin family, Adderall family, methylphenidate, amphetamine salts, about equal effectiveness. It seems like the younger kids I see, I have a more methylphenidate. The teenagers and college students, I might have a little bit more on the Adderall type compounds. Of course, we're all aware that folks can misuse these and divert these. Studies say that all the medical students tell me that more than 10% of their peers do this. The studies say it's 10%. Everyone seems to think it's more than that. But as far as folks that take some of these medicines for performance enhancement or they share with their friends, um, you need to be aware that you could get in big trouble. In some states, it's a potential felony to share your medicines like that. So I wouldn't take that chance. That's why I do urine drug screen for all adult patients prescribing the first time. Because if someone's already using other drugs, I typically do not prescribe a stimulant. Um, in general, for the dosing of these, 1 milligram per kilogram a day for the methylphenidate family, half a milligram of kilogram per day for the amphetamine salts, because the amphetamine salts are more potent. And then I like to know, like, what's the gentlest member of each family? Probably the gentlest member of the Ritalin family is dexmethylphenidate, which is Focalin, because he's like, is it an enantiomer? So I always tell patients it's a simplification. Oh, they took out all the bad junk. They purified it. That's what I say. And then lisdexamphetamine, that's Vyvanse. That is probably the gentlest member of the Adderall family. And it's a prodrug. So if you snort it or inject it, doesn't really do much for you because it has to go through your gut. And then the enzyme, the Lis amino acid, gets cleaved off and activated. So it may be lower abuse. Antipsychotics almost always cause some degree of weight gain, at least the ones that work. This is a shame. We thought, oh, good, we got rid of all those old antipsychotics like Haldol. Ugh. Well, Haldol causes its own bag of side effects. The newer ones cause their own bag of tricks as far as lots of metabolic syndrome. There's still a risk of tardive dyskinesia, although not as great. There's one called ziprasidone, Geodon, and some other newer antipsychotics that promise less weight gain. The problem is we have not really shown, those to be as effective. Pretty much when it comes down to it, clozapine is the gold standard for treating the hardest to treat schizophrenia. And before you get to clozapine, risperidone and olanzapine, usually in head-to-head kind of stuff, are shown to be more effective than the other atypical antipsychotics we're talking about. But I use some risperidone, for aggression in kids. It's well studied. For aggression in the context of autism, risperidone or aripiprazole are reasonable. I mean, you try the things first, but if other things are already being tried and there's still, significant issues, then we will prescribe these medicines. Mood stabilizers. This name, I wish they changed the name of these. Since they're called mood stabilizers, people go on the internet and they go, oh, mood stabilizer. I know a moody person in my life. They need the mood stabilizer. They say, no. It doesn't really just help every kind of mood. It's really reserved for bipolar. Even though there, are some medicines like lamotrigine or, I don't know, oxcarbazepine, lithium is probably the gold standard. Lithium gets a bad rep. Over the years, I've grown to appreciate lithium more and more. I think lithium can be effective. Yes, we have to watch for some potential side effects. But I like how lithium does not cause polycystic ovarian syndrome in women as valproic acid can. But those are probably the two gold standards as far as most effective. Now, all antipsychotics have some mood stabilizing properties. So if you see a patient with bipolar and they're only on an atypical antipsychotic, that's reasonable. But I think that the harder to treat bipolar is, lithium is about as good as it gets. And you got to be real careful that if you think someone might have bipolar 2 or bipolar 1, if they also have depression or ADHD, don't give someone a serotonergic medicine or stimulant without them already being on a mood stabilizer. You can cause mania. You can cause rapid cycling where you have a bunch of different mood changes within the year. And even though we're super scared of valproic acid and carbamazepine for pregnancy, I've never seen a case where they give those during pregnancy. Lithium, I've seen in a number of cases where folks are continuing on lithium throughout the entire pregnancy. They get ultrasounds, fetal ultrasounds. I mean, we're always worried, Bird's question, Epstein's anomaly. But lithium's not a total deal breaker. Same with another question on boards is, ECT, what's the absolute contraindication to ECT? Nothing. Pregnant women can ECT, old people. There's some things that are relative contraindications, make us more skittish about ECT, but there are no absolute contraindications to ECT. Just a side one there. Hypnotics. The key is almost everyone has sleep problems. You got to go through sleep hygiene first, especially with the teens I see, especially the kids in my own household. Put the screens away. These screens are, their own addictive kind of thing. They've trained us to be Pavlovian dogs. There are things, I guarantee you that if we have problems sleeping, there are some sleep hygiene things that could be improved. Now, if you make a concerted effort to try to improve some of them and still can't sleep, it's okay to try a medicine. I like melatonin. I think it doesn't work for everybody, but for initial insomnia, it's okay. For phase delay sleep issues, jet lag, it's pretty good. Even though there's like very weak evidence for it, myself and every other psychiatrist I know prescribes a bunch of trazodone. Pretty good for staying asleep if someone has trouble staying asleep. And then actually Zolpidem, Ambien. I'm not so sure about Lunesta. I do give a little bit of that, but most of the sleep doctors I know, their favorite is Zolpidem. The Z drugs. They're the non-benzodiazepine sedative hypnotics. They really don't seem to change your sleep architecture much, which is nice. You don't want to really change your typical sleep architecture. So benzos, Xanax, super tricky. I don't dance with Xanax very much. Xanax is highly addictive, a lot of abuse potential. I think it's because it like kicks in pretty hard, but then it leaves you pretty hard, and so you end up chasing your tail sometimes. Almost like what can happen with pain meds sometimes. I more often use lorazepam for short term, and when I want longer term relief, I give clonazepam. Now Stevie Nicks or the old Fleetwood Mac group, the one from that TikTok thing recently, she was hooked on clonazepam, so it can hook you, but I don't think it's as bad as Xanax. And I use benzos. I like them just spot checking, occasional use for performance anxiety, and also initially when giving a benzo when someone doesn't have time for the SSRI to kick in. Like example, college student I saw a long time ago came to college, socially anxious, was panicking every day, multiple times a day, said, I want to drop out of school. I'm thinking, uh-oh, we don't want to have a college dropout. I started a benzo. At the same time, I started a sertraline. Gave benzo for about 2-3 weeks, titrated up the sertraline, took away the benzo, kept the sertraline. Student did wonderfully. Graduated 4 years later. It was great. And benzos are for little kids and old people. Be careful. They don't work as well for little kids. Little kids sometimes get more disinhibited. One kid I saw, I got a call at night. I gave a benzo, and this 12-year-old, the parents called me about midnight and said, our kid right now is naked, running around the house, stole the baby's diapers, and is saying it's diaper time and whipping diapers around the head, dancing on the furniture because they were uninhibited from the benzo. Whoops. And then old people, if they fall and break a hip, half of old people go to the hospital with broken hips, never make it out of the hospital. So you don't want to take that chance either. So you got to be careful. And then the other thing I'll say to folks if they're getting pushy about a medicine, I said one example earlier, but if I've decided there's no way I'm prescribing this stimulant. I had a college student one time who was taking, I think, 130 milligrams of Adderall and hallucinating. I said, you're done. No more stimulants. His mom came in, please give him the stimulant. This guy was like 23. Mom came in, was crying, please give him the stimulant. And I kept saying, stimulants are off the table. My line was off the table. What else would you like to discuss? I have some other things off. And they kept saying, stimulant. Nope. We've already discussed that. That's off the table. What's the next thing? And so I think it's okay not to engage. If you've already explained things, we're not going to bargain here. We're going to move on at some point. Pharmacogenomic testing. Ooh, this is the latest, right? It solves all our problems. I wish it did. Pharmacogenomic testing tells you, it's basically a good educated guess as far as how do our genes affect metabolism of meds. The cytochrome P450 enzyme things that you might have been tested on. The problem with pharmacogenomic testing, one, it's pretty expensive, getting pushed. Number two, it doesn't really tell you what works. In fact, I've had some patients where their genomic testing said, never get this medicine. And like the medicine, I ended up choosing that medicine and it like saved their lives. So nice, we tried it still. Because I've had stuff like, it's like red light, yellow light, green light. Oh no, red light, stay away. But it does tell you that, yeah, maybe they're a slow metabolizer of something. So I mean, I don't mind avoiding medicines if there's a ballpark idea that maybe this could be one that's a trickier metabolic choice. And there's some famous cases like HLA testing in Asian patients before carbamazepine, board style question. You don't give it to Asian patients if they're positive for this HLA B1502. Luckily tested recognition, not recall. I can't remember that because of Stevens-Johnson syndrome. But in general, I don't really need the pharmacogenomic testing to tell me. I always start low. If someone is a slow metabolizer, they might respond at a lower dose. They also might have side effects at lower doses. It still doesn't change how I practice. If they're a fast metabolizer, it means I've given them a pretty high, I've maxed it out. They have no side effects. They're not getting better. For a psychiatrist, my maxed out is higher than people's maxed out. Then I'm probably going to have to switch to a different medicine or maybe give a higher dosage. But that's how you usually manage it. I don't use the testing typically. And the final one, this is one of the favorite ones. I stole this basically from the APA, American Psychiatric Association. Well, it's part of PsychSign. A long time ago, I went to an APA talk. An eating disorder specialist said, when I work with women and men with eating disorders, I have to treat the eating disorder as though it's the bad boyfriend. This could be like the bad girlfriend or whoever, but someone that's in your life that's bad news. Because how do people respond? Like if you have a bad partner and one of your friends says, that partner is bad news, get rid of that partner, they're a jerk, drop them now. Oh, you're gonna be, oh yes, I must drop this bad person right now. No, you defend the bad person. You think, oh, my friend doesn't know how he treats me so nice when we're, you tend to defend it. And so you don't want to come hard at if the patient feels like cutting is my only way to cope currently. You don't want to say bad patient, that cutting's so nasty and you like that nasty cutting and makes you nasty patient. You really have to be much more like supportive and deliberative and plant seeds about like, oh, you say you really love your boyfriend, how do you feel about the nights when he's out with Susie and posting pictures with Susie? Oh, yeah, you bring up a lot of questions, or you really like the way you're eating, but how do you feel about the way your teeth are now? And so I think it's a really great way to approach patients with anything that sort of society frowns upon, that they feel very judged by in terms of things that they keep secret, is to really treat that thing as though it is that bad boyfriend and don't come at it super hard and very judgmental way and saying like you need to do this. Telling people what to do never solves anything. They have to on their own eventually with your assistance decide this is not good for me, it's not healthy, I'm moving on. So I just love thinking about a lot of the conditions as a bad boyfriend. So then my approach is more deliberative and I'm not being as punitive. So all right, and I'm thinking I forget what time I even had till, but I'm at the end. Can anyone name that movie on the left? The final screenshot of what movie?
La La Land.
Yes, excellent, good job. I appreciate that. Okay, so now I'm going to stop the share, and I don't even know how much time I have left, and if anybody has any questions. I don't know if we're gonna. Yeah, if you want, is there anything from the chat or?
For questions, and it looks like someone asked a question in the chat, which, or more like a statement, I guess, that they probably want you to comment on, that they had a primary care preceptor who really advocated for the pharmacogenetic testing for treatment-resistant psych patients. So if you could just.
Yeah, I think the times when I think pharmacogenetic testing is most reasonable. I don't think it's always bad, but I think the problem is I think it's sold sometimes as something that everyone should be getting. I think if someone has failed a number of medicines, like they've had trials and they had either side effects or lack of response, I think pharmacogenomic testing at that point, once you've maybe had 3 or 4 trials, if you need that many, can maybe give you an idea of like which medicines have not been tried and what are most likely to be tolerated in terms of their side effect profile based on the enzymes. I also think that if you're going to start giving someone medicines that are a little bit dicier, like tricyclic antidepressants, those I'm more concerned about maybe having folks be slow metabolizers because I don't want to have major cardiac events. SSRIs are so gentle that I've had a lot of patients overdose on SSRIs. Almost none of them were harmed. I mean, they don't even usually keep them that long in the hospital. So in the old days when we would give a TCA, it was like handing a loaded gun to someone. I still use TCAs a little bit, but I think for some of the medicines that are dicier in terms of their side effect profile, yes, I'd like to know the metabolic profile a little bit better. But once again, even the testing doesn't tell you for sure that it's still a bit of an educated guess. But great question. I don't mean to say you never do it, and you almost never say never in psychiatry. But once again, I think it's either with certain medicines like citalopram. That's a medicine that's a little dicier because citalopram we think can be maybe have some cardiac effects at certain higher doses. But in general, do most patients need this? No.
Feel free to just unmute yourself and ask a question if you have it, or write it in the chat.
Yeah, just you could. I'd like to hear voices. I taught a class with 300 students last semester. I don't think I heard any voices. I know it's also hard because I was jumping from topic to topic. It's not like one unified thing, but like I said, if you try, when you actually have patients, try out some of these things and see if they work. My residents have found a lot of these pretty helpful when they're like, what do I say in this situation? Or how do I, and then it's like, oh, good. It's sort of like when you're taught in med school, even though when you say it, at first when you say it, it sounds canned. Like, how does that make you feel? You've probably been asked to say that in your actor patient interviews. And when you're asking some actor, how do you feel? Some of you are probably thinking like, this sounds like I'm in some bad like Hallmark movie or something. But patients, I've never had a patient be like, you're just saying that or something like that. If you repeat it enough, it's a good question. Eventually it feels more real, or it should feel real with real people. Although I will say the actor patients, sometimes my real patients, I'm almost like, wow, these remind me of the actor patients I used to see back when I was a student. So this is not all for naught, but I do think some of these things, if they might not seem unnatural in some ways when you take them out of the context, but in the context of the interaction with the patient, a lot of these statements can be very powerful. All right. And if there are no questions, that's okay too. I mean, I know you're from all over the region or whatnot. I mean, if any folks ever want to reach out to me or whatnot, if you have questions about psychiatry, I'm assuming that many of you are considering psychiatry as a career. The fact that you're in this today, I already said earlier, I think it's a wonderful career option. I know so many happy psychiatrists. I can name so many people that switch out of other areas of medicine. Not that those are bad, but I think you got to find what's best for you. But so many people I know, like from orthopedic surgery and OBGYN, that either during residency or even later in life, after 10 years, 15, 20 years of another field, switching to psychiatry. I went straight through, so I don't know what it's like to make that switch. But I think it's great that really about 2/3 of folks that choose psychiatry as a career, entering med school or even early med school, have no clue that they might ever become psychiatrists. Like it's not even in their top five. So if you came in like that and not sure, that's not unusual at all. It's actually more normal in some ways to be figuring this out as you go through the process. But once again, I think for most of you, probably will be a really life changing kind of thing. Last call. All right, going once. You can call it.
All right. Thank you so much, Dr. Smith. Your talks are always super fun and easy to listen to.
Okay.
And appreciate some of the board review in there too, because I'm taking my shelf soon.
Excellent. I try to sprinkle it throughout. I always do that. That keeps them, especially keeps it like that special spice I put on my stuff is my MBME, because I just submitted more MBME questions. So yeah, hopefully I don't by accident say anything, but you never know. Okay. Have a good day, everybody.
Thanks, Dr. Smith. Take care.